So now moving on into our agenda here, I get the opportunity now to formally introduce Dr. Jen Layden, who was our surprise welcome earlier today. She's going to give us an overview of the CDC Data Modernization Initiative and Public Health Data Strategy. Dr. Layden is the director of the Office of Public Health Data, Surveillance, and Technology at the U.S. Centers for Disease Control and Prevention. In her role, she's responsible for strengthening CDC's scientific foundation, providing leadership for the CDC's Data Modernization Initiative, and serving as an advisor to the CDC director. So Jen, welcome.
Thank you, Judy. And again, great to be here. And I want to just continue to emphasize a couple of the key points that I took away from Dr. Shah's talk. One is the need for transformation. We are really at a pivotal moment in public health that we need to not just make iterative progress, but look at what we need to transform. And then the second is the unified approach. There's so much work to be done, and how do we do it collectively and together? So I wanted to provide just a little bit of overview of some of the work that we're doing from a national perspective on the data modernization effort, as well as on the public health data strategy. Before I start, I wanted to I had the opportunity to visit one of the Amazon fulfillment centers yesterday, and last night, I have two teenage kids at home, one of them a daughter who likes to shop. I noticed that she ordered something on Amazon late last night around 10 p.m. I don't know what it is. I will find out when I get home. But this morning, I got a notification that it was at my doorstep. And not only was it at the doorstep, I had a picture of it on my phone that it was delivered to the house. Hopefully it was something useful. But that goal of getting something delivered to the end user didn't happen overnight. It was probably a lot of iterative progress, but the technology was there and it can make it happen. In public health, how do we take some of that technology? How do we take the data? How do we take the thinking, the way private industry has worked to make public health better? So when I think of public health and the transformation that we need, I like to go back to what is the core mission of public health, and we'll hear that theme a lot, and I think it's really important to have that. When you go back in history to data and surveillance, back in 1912, their case notifications were being sent from states to the CDC. There were 5 diseases that had to be sent immediately by telegraph. There were 10 diseases that had to be sent monthly by letter. 10 years from now, where do we want to be? Where should we be? Defining that bold, audacious goal of where we want to be and need to be so that we in public health can monitor, detect public health threats for the betterment of our nation, our communities, to prevent diseases, prevent outbreaks, and improve health outcomes. I think it's something as a public health community and with community members, with private industry, defining that 10-year goal and then taking those steps to do that consistently is something that I think we as a community need to really land on. So where we are, when we think of DMI, data modernization, it's really a long-term goal of where we need to go so that we in public health can meet our mission and serve the nation and our communities. We want to move to a state where our systems are connected, they're interoperable, where data can essentially be transferred in near real time, so that whoever needs to use it, whether that's the clinician, the local health community, the local health department, the state health department, the national level, can use it for that intended use to improve outcomes, shut down outbreaks, inform those that rely on that information. When we think of how we've traditionally done public health, we've relied on core data sources, which are vital and need to continue. And we've seen great progress in the data modernization effort to move that data faster. There's still a long ways to go. But I think we're also seeing this space where, as we're thinking of our need to monitor and detect, there's additional data sources out there. There's additional signals. And how do we look at those to make the way that we detect and monitor better? Right? How do we use that information? How do we transfer that information to enable those that need to do the job can do it? And that's just not at the health department. How do we get that data back to the clinical provider? How do we get it back to the individuals at their homes, at their schools, who also want that information to make their own decisions or make their decisions for their environment? So a bit about the data modernization effort. This is something that has been long needed in public health. It was initially funded in 2020 with a small bolus of resources. And fortunately, over the last couple of years, public health has benefited from some of the additional COVID funds that were provided to public health. Not enough compared to what we know the true needs are, and we've been impacted by the COVID rescissions. But I do want to emphasize that we already are seeing the positive impacts of that. When we talk about the work that's been done over the last 3 years, in the context of also public health having to respond to a major pandemic, it is quite impressive. We went from less than 200 hospitals being able to send electronic case reporting to over, I believe it's 28,000 now, sending electronic case reporting. We have a syndromic surveillance feed with just under 80% of hospitals now being sent to healthcare departments, and that's almost near real-time data, and the race and ethnicity data is complete, or nearly complete, 90%. So there's been a lot of improvement. Vital statistics, death records are being sent faster, and that allows us to identify more severe trends, not just for COVID, but there was a recent report that came out looking at suicide trends. So us to be able to detect those new trends and report on it to inform action are happening, and it's because of the benefit of those resources. Susie Connor, our CIO for CDC, will talk a bit about the North Star architecture later, but just to put it into context of consistent with that unified approach, we need to have a unified blueprint so that as modernization efforts happen at the national level, at the state level, at the local level, and across programs within the national level, the state level, and the local level, we're doing it in a way that's interoperable, that there's consistent standards, there's just consistent prioritization, and we're breaking down those silos. So we're not having data sit in one system. When I was at the state health department, we had data in one system and a data in other systems, and the two programs didn't talk to each other. Right? The data was there, it could be used for really important efforts, but the data technically couldn't talk to each other, but there was also policy challenges. So really looking at how across this ecosystem of public health, we look to break down the silos, we make our systems interoperable, we have a blueprint that is agile enough to continue to evolve as newer technology, new approaches emerge. Knowing that we need to set that bar of our bold goal for 10 years, we have been working on a public health data strategy. And this was really to help start to unify and define high priority short-term goals. During COVID, some of those challenges and barriers were highlighted, and certainly people recognized and experienced it, not just within public health, but community members. When we start to see websites being posted by others of accounts and not being able to rely on public health dashboards, people started to ask those questions of where we need to go and where are the gaps. So knowing those gaps and seeing those highlighted during COVID, we've defined 2-year goals, as well as very concrete milestones to help the efforts across our jurisdictions move the needle on some of these key priority areas. So this is a little bit of a complex slide, but it's one that I think speaks well to the complexity of the public health ecosystem from a data and system lens. In public health, there's no one end user of the data, there's no one sender of the data. It's quite complex. Data often starts in the healthcare setting, but it also starts in other places as well, whether it's the lab or other settings. That data gets transferred most often directly to the state and local level, and then some component of it gets sent to the national level. Ideally, we want to get that data back to the healthcare setting as well. When we think of those that need to rely on the data to use it, it's not just the state and local level, it's not just the federal level, but it's also our community members, it's our governmental officials. There's multiple senders of the data, there's multiple users and people who rely on that data. In this process, we've seen multiple challenges. We know that it's very burdensome on those that send the data, those that have to enter it into systems. When I was in the state of Illinois at the start of COVID, one of the hospitals, even though we had an electronic case system, one hospital had 15 people who had to type the data into that electronic system. We requested data at the national level from multiple different ways from our state and local partners. So how do we address not just the technical challenges, but the administrative, the policy, the processy challenges to ensure that there's more cohesion, unified, and we're breaking down the barriers in addressing the challenges that we need to in public health. So going back to the public health mission, as we set the strategy, we really wanted to put it in the context of what's the mission that we are responsible for in public health. Public health is there to save lives by detecting threats, monitoring for new changes, new evolving variants, responding when there is a threat. So when there's a Legionella outbreak, going there, figuring out what the cause is, shutting that down so additional individuals don't get sick. When there's a foodborne outbreak, detecting what the source is, getting the message out, pulling the source of exposure so additional individuals are not exposed to it. So keeping that mission of what public health has to do, defining then 4 high-level goals. Recognizing this is not the totality, but again, to help to prioritize the work over the next couple years. So the first being the strengthening our core systems, our core data sources. I do believe that, as we look 10 years out, we need to look beyond our core data sources for other ways to monitor and detect, but we also know that these core data sources will continue to be pivotal across public health. So case data, how do we get that case data from the healthcare sector to the various actors across public health jurisdictions in near real time? It's not acceptable to have to wait multiple days to receive that when there are lives that are impacted by that data being viewed by someone who can act on it. So case data, how do we get it quickly to all those end users that need it in near real time, more complete, and higher quality? Lab data, similarly. Lab data is not just a key data for identifying cases, but really an early situational awareness indicator. Who's ordering tests? Is it rising? The percent positivity going up? That's an early syndromic surveillance signal that we can use to identify emerging or changing threats. The second goal is about how we prioritize and build and support solutions that support state and local jurisdictions. We recognize that so much of the work happens at the local level with community members. They're investigating cases day in and day out. They're identifying outbreaks. They're isolating individuals. They're quarantining individuals, getting vaccine to those that need it for a variety of illnesses, not just COVID and flu, but when there's a rabies exposure, ensuring that individual who is exposed, they don't stop until that individual gets that vaccine. So how do we ensure we prioritize tools and solutions that support the uses and needs of our state and local partners? Second goal. Third goal is getting the data and information out there. There is a expectation and a need to ensure that we can better package information in a way that's meaningful, understandable, usable by the different users. So not just those within public health or those that use it for research purposes, but that interpretation of the data in a way that a mom can use it to understand what she wants to, decisions about family travel or sending her kids to school or whatnot. So doing a better job in meeting the needs of those that want to use that data information. And then the fourth, really consistent with that unified approach, how do we get our systems across public health to be interoperable? Data elements consistent and standard, functional data, technical standards for our systems so that data can flow more seamlessly. I mentioned these before. These are some of the core data sources that we consistently rely on and that there's been great progress to continue that modernization pathway. There's still progress to be had, and we very much welcome innovation in technology solutions to make that happen faster. We also want to look at those additional other ways that we can monitor and detect for public health threats. And one question we get quite a bit is, what's the difference between the public health data strategy and the DMI effort? The data modernization effort is a long-standing effort that'll be around for some time. Public health data strategy is there to laser focus us for the next couple of years on addressing some of those those barriers, challenges that arose that we need to solve quickly in public health, and do it in a unified way. At CDC, we've just stood up a brand new office that is solely dedicated to a public health data strategy, helping to coordinate the efforts across the agency as well as our public health partners. We are increasing the type and frequency of engagement, not just with our state, local, tribal, territorial partners, but with others, private industry, academia, to ensure that we're engaging, we're bringing the broad scope of skills and expertise that are needed for this effort. And then lastly, a core principle that we really are emphasizing within our office in the public health data strategy is the end user. So what are the needs of the end user? In defining our goals, defining and prioritizing our solutions based on what the end user needs, and recognizing that there's multiple end users. Maybe it's a state and local health department who relies on access to that data of a measles case that's showing up at the emergency room. Or maybe it's the public, what do they need? And then incorporating that perspective into the solutions and tools that we prioritize. So just to close with saying that to do this and to do it well and to meet that bold goal of where we want to be in 10 years, we need the help and support. We need the partnerships. We welcome the partnerships. We welcome knowing what we don't know. Public health is very mission focused, and people who work in public health are passionate about what they do. And they want to do better. They want to serve the community and the nation. And so look forward to working with all of you, hearing your solutions and ways to increase the partnerships across public health and with you all. Thank you.